So let's start this talk. I decided to call this Utilization of Artificial Intelligence to Enhance Detection of Cardiovascular Disease. I actually wanted to go to a presentation in 2020 in San Francisco that Mayo was putting on AI and cardiovascular disease, but the program was canceled because of COVID. But then they put a program on in February of this year, Current Applications in the Future of Artificial Intelligence in Cardiology. So I went to that meeting in February, and I had the opportunity to meet I went to the course. That's the proof that you can't get reimbursed for going unless you have proof that you went and receipts and that sort of thing. So anyway, I had a chance to meet Dr. Anthony Chang, one of the world's experts in AI and cardiovascular disease. And this is the title of his book, Intelligence-Based Cardiology and Cardiac Surgery. The objectives, so after going to this meeting, I ran across some new technology that we're going to bring to Fairbanks. And we'll talk about that in a while. But we don't have the technology yet. I hope that it was going to be available by April. And I've been promised that it will be available hopefully by the end of the year, but we'll see. I promised the hospital that the first 3 months are free. It won't cost the hospital anything for the first 3 months. And then we'll see what happens after that. So I want to give a brief history of ECG. I love electrocardiography. And some say, well, why do we say ECG versus EKG? Well, we write ECG. Generally, we say EKG, so that if we say, I want an ECG, one would not think we're saying EEG. But so you can say EKG or ECG. So I want to give a brief history of ECG and show some clinical scenarios on how we look at an EKG and what we can determine in terms of what's going on with an individual. And then introduce some new terminology that may be new to some of us in terms of AI, data science, machine learning, deep learning, and also identify some emerging trends that are going to be available with the utilization of AI. So the heart is a muscular pump. And actually, so next week, I don't know who's coming next week, we have a new vascular surgeon with our group, Dr. Umbrellero, who's speaking on the 11th. And the title of his talk is, Forget About the Pump, It's All About the Pipes. He's a vascular surgeon, so that's his title. So, but if you don't have the pump, it won't matter about the pipes, okay? So the heart is a muscular pump, but it has electrical activity also. And the EKG is a recording of that electrical activity within the heart. And Harper, are you going to help me here? There we go. And so here you can see this is an echocardiogram on the right. And this is a view of the left ventricle. And it shows a nice normal heart in terms of its squeezing. And on the left there is an EKG, a representation of the electrical activity of the heart. Generally, there are 12 leads that we look at. And the different leads will give us a different perspective of various regions of the heart. So we're going to look at some EKGs. This picture shows, in terms of where we place electrodes on the chest, 6 electrodes on the chest, and then we have electrodes on either arm and leg to generate this tracing. Now, the first EKG was first performed by Augustus Waller in 1887. Waller had decapitated a cat, and before the heart stopped beating, he recorded electrical activity by opening the chest cavity and putting electrodes on the heart. And he thought to himself, you know, we could probably do this without killing an animal and maybe putting it on the surface of the animal. So he felt that a human being would be an easy animal to get, so he chose himself. And then when he presented this information to the Royal Society, he used his dog, Jimmy, to show this, right? And it was the first time I wanted to show that you didn't have to open up the chest and expose the heart to do a tracing. Now, the Animal Rights Society did question this about how he used Jimmy, but I found it kind of interesting. They had nothing to say about the cat being decapitated, but they were concerned about Jimmy. And so his first tracing is here, which is barely, doesn't look like what we have now in terms of EKG. But then Einthoven in 1895, with his electrometer, had more of a tracing in terms of what we see in today's time with the EKG. And Einthoven later, utilizing a string galvanometer, produced what we currently see in terms of a tracing with an EKG, and that was in 1901. If we look at further on in history, Einthoven did get a Nobel Prize in 1924. In 1954, what we see now, or what we utilize now as a 12-lead ECG, was first standardized by the American Heart Association in 1954. Now, in 1976, I was taught to read EKG by Dr. George Birch, the cardiologist who was director of the Department of Medicine at Tulane University Med School. And so it was interesting that one could go to Dr. Birch's course if you wanted to take the time to do it after hours. And then it was wonderful. There was only about 7 or 8 of us in class. And then after class, 2 or 3 of us would go with Dr. Birch and Dr. C. Thorpe Ray to slice hearts for autopsy cases at the VA hospital in New Orleans. So we would look at the EKG and slice the heart to see what the EKG was showing us in terms of his heart. So there was tremendous training to do that. So when we look at an EKG, we can get insight into what's going on with the patient. So here's a chest X-ray on the individual, and this heart is huge. Normally, the heart should take up about half of the chest cavity. This heart is taking up about 2/3, maybe 3/4 of the chest cavity. So an EKG on this individual, one would expect to show a lot of voltage because it's a huge heart. That's what one would expect. And here's this echocardiogram showing a very thick heart. This is a lot of muscle here. And here's the person's EKG. There's not a lot of voltage. That's very little voltage. We would expect that to be 3 or 4 times that size. So as a cardiologist, when we see this and a heart that's thick, we know that muscle is infiltrated with something. And what we normally see in older individuals is a condition called amyloidosis. This person had amyloidosis, and so to diagnose it, we do a scan, a technetium pyrophosphate scan, which is shown here, and normally the heart should not show up at all. We should see the ribs and maybe a faint representation of the heart, but you see this heart is lighting up, right? So that's very positive. Unfortunately, this patient was diagnosed before there was any treatment. We do have treatment now to slow down this process, but 10 years ago, when I was taking care of this patient, there was no treatment for it. And here's an EKG, and this is what, in terms of cardiology in Fairbanks, this is why we're here. When someone comes in with what's called ST elevation MI, that's elevation of the ST segment, we know that we have to get that person from the ER into the cath lab and get the artery open, hopefully within 90 minutes. Within 60 minutes is even better. So here's a case that we did of actually a young person, about 31 years old, with an artery that's blocked completely, who came in with an ST elevation MI, opened the artery up, and placed a stent, and the patient did fine. Now, with this tracing, when you look at it, that's lead 1 should not look that way. Lead 1 should look like the lead just to the right of it. So it's, if you put the right arm electrode on the left, you get something like this. However, if the chest electrodes show you that the voltage is dropping off, well, it may be that it's not because someone put the leads on wrong, it's because the person's heart is actually on the wrong side. This is someone with situs inversus, with the stomach over on the right rather than the left, and the heart, rather than being on the left, is over on the right. So, so this is the stomach on the right rather than left. So, yeah, this is situs inversus. and we can diagnose that from EKG. So without reading EKGs, there's certain rules. How much voltage? How wide is the QRS? What's the rate? What's the QT interval? So we have certain rules that we go by. On this tracing, and this was from a patient who, it was in the winter, and they found the person out unconscious on the road and brought him in. And what we see here are what's called Osborne waves or J waves in someone with hypothermia. So this person came in with a body temperature of 77 degrees. 98.6 is normal and 77, and which is severe hypothermia. So in hypothermia, when it gets down to about, in his 77 or so, there's increased risk for asystole where the heart may stop. That patient survived, actually. I've seen more people survive in Fairbanks with cardiac arrest and things of that sort than many other places. Are Alaskans tougher, or just the type of people who come here? What are they drinking? I don't know, but they they tend to survive. And then this is an EKG where I have tell students, if you see this and you call the cardiologist or whatever, just tell them what you see. This is a wide QRS tachycardia. And this is a spiraling type of ventricular tachycardia that's called torsades de points, twisting of the points. When we see this, we say, oh, okay, the person may have a low magnesium, may have a low potassium, maybe there are certain medications they're taking that's causing the heart to become so irritable that it's racing away this way. And this patient had a potassium level, normally it's 3.5 to 5. It was 1.5. And the patient was treated and actually did fine. Now, this is, there's a problem with being human. And that is, you run across information and data, but you can only remember so much, right? Well, there's a lot of information out there, but you just can't feed it to, you have to go through years of learning and teaching. You have to read and read and read. You have to avoid, you can't always go out and fly drones. You can't watch all these sports. So this finding, I just ran across this about a year ago, but this was first reported in 1958. It's just interesting. So that's one thing about AI with deep learning. We can just feed all this data into these supercomputers, right? And with using algorithms that are layered, they can take this data and then we can ask questions and get answers and information. There's just so much more we can do when we're not dealing with the limitations of being human. So in this particular case here, this notch in the QRS, it's called a crochet sign or crocheted sign. And if we notice this on EKG, there is about a 27% chance that someone has an atrial septal defect or an opening in the heart from one chamber to another. So here's an example. This is what we call a saline bubble study to look for that. And see, the bubbles will come over to the other side. That shouldn't happen, all right? So if we see that on EKG, we say, oh, that person may have a PFO. So if you do have a patent foraminal valley, there's increased incidence of migraine headache. There's increased risk for stroke. Anytime I see this on a patient, no matter what age, generally these are young adults, older adults, I would have them take an aspirin a day. But EKG is something that we can look for to see if someone has that. Now this is an EKG from someone at Mayo Clinic. And it was read as normal, and I would not have read it as normal. I would have read it as probable left ventricular hypertrophy, but I would not have read it at anything more than that. It was read as normal. But Mayo has this process now where all of his EKGs go through AI evaluation too. And the AI evaluation said there was high likelihood from this EKG that this person had a very weak heart. So they sent the patient for an echocardiogram and found that the person had an ejection fraction of about 18%. Very low, very weak heart. So as I mentioned earlier, in terms of the traditional way of reading EKGs is through just linear rules, just rules of what's the voltage, what's the QRS restoration. But with AI, what has been done through Mayo Clinic and through a company called Anumana is that over 100,000 ECGs from Mayo Clinic, along with patient records, have been placed into large computers. And this data has been evaluated to make associations between the findings on EKG and diagnoses so that the AI can then make these associations between EKG and various findings. So when I said I would call it left ventricular hypertrophy, we look at what's called the deepest S wave on EKG, and that's 20 millimeters. Look at the S wave in V4. If it's 23, if you add those, if it's 23 or more, then there's an enlarged heart in a woman. If it's 28 or more, it's an enlarged heart in a man. That's why I said I would call this LVH. Now, so here's this young man's EKG. His sister had died suddenly. That's why he went to Mayo for an EKG. It was read as normal, but the AI suggested that no, the patient had a low ejection fraction, and the patient was sent for an echocardiogram and showed that his ejection fraction was 18%. So if we look at intelligence versus artificial intelligence, well, intelligence may be defined as the ability to learn from experience, to adapt to new situations, to understand and handle abstract concepts, and to use knowledge to manipulate one's environment. So what is artificial intelligence? Well, it can be defined, as Marvin Minsky defined it, the science of making machines do things that would require intelligence if done by a human. Things that would require intelligence done by a human. Now, Marvin Minsky was renowned for his work with robotics and computers, and has apparently has a lasting impact on science and computer science. If we look at artificial intelligence versus machine learning and deep learning, well, machine learning and deep learning are aspects of AI. AI is any technique in which we enable computers to mimic human intelligence using logic. Also, the if-then situations, what do you do? And also decision trees. Deep learning is using layered algorithms and just using very complex algorithms to help the machine to not only to analyze, but also to improve and to learn. So data, having information to feed into the computers is very important, having the data there. But it takes more than just having data, right? We have data, and the data means nothing until you give it a perspective. And or a context. You put it into context, and then we have information, and then you have to know what to do with that information. As a physician, as we get used information, we can decide on what this means in terms of the knowledge to know that someone has a weak heart or a thick heart or atrial fibrillation. Then we can move on to wisdom in making decisions on what to do about that information. But it all starts with data and being able to handle a large amount of data. So as we move from CPUs to GPUs and go on to quantitative computing, we're going to be able to handle more and more data to understand what to do about these situations and how to handle the data to get more information from our patients. So with convolutional neural networks of deep learning, they can detect signals and patterns largely not recognizable by humans. It can detect LV dysfunction, silent atrial fibrillation. It can look, the AI can look at an EKG that looks completely normal to me, but know that that person has had bouts of atrial fibrillation. And that's all based on patients with diagnoses of atrial fibrillation, but with EKGs that were normal within weeks or months before they had a bout of AFib. So there are little changes in the waves that we can't perceive that the AI can because of making these correlations with the data. They can also determine a person's age, sex, and race, and other phenotypes. The AI can enhance our accuracy, the speed at which we work, and give us a more comprehensive analysis. Let's go here to this slide. So let's look at the role of AI in diagnosing low ejection fraction. Now, ejection fraction is the percent of the amount of blood that's ejected with each heartbeat. Normally, ejection fraction is somewhere between 50 to 60 to 65%. And if we look at this heart, on the right, that's a very low ejection fraction. It's squeezing only a small amount of blood out with each heartbeat. Whereas on this side, it's a thick heart, but the ejection fraction is normal. That's the normal ejection fraction, greater than 50%. On the other side, less than 50%. So Anna Mana looked at over 100,000 EKGs and patient records for Mayo Clinic, but they have to date looked at over 10 million EKGs with associated records to make associations in terms of the findings on EKG and the clinical presentation with patients. This is an EKG from a physician at Mayo Clinic. Now, on the left here, it says that it's a male, 39 years old. On the right is the AI interpretation, and it says that he's about estimated age 37.3, probability of being male 98.6%, estimated ejection fraction normal at 58%, and probability of low ejection fraction less than 1%, probability of undetected atrial fib less than 1%, and probability of hypertrophic cardiomyopathy less than 1%. So right now at Mayo, every EKG goes through the AI, and they get this information on every patient. But this is just the beginning. At the conference, they also talked about the fact that with AI, they can now tell if the heart is stiff. We call that, when patients have a stiff heart, you can develop heart failure with a normal ejection fraction. They can tell if the heart is congested. There's so much more. And then later, we're going to be able to, and I'll show you this in terms of what they're submitting to FDA, determine whether someone has high blood pressure in their lungs, pulmonary hypertension, all with seeing little nuances in the waves of the EKG. So again, there was a 35-year-old male, and who the EKG was read as normal. The AI said 76% probability of a low ejection fraction. And so with that, they said, oh, well, let's get an echocardiogram on this young man. And the echo showed that his ejection fraction was 18%. So so they placed him on medical therapy, and they actually found all the family members who had low ejection fraction. So with this enhanced ECG interpretation, we can streamline the human capability. When we use this, the AI is not going to take the place of the cardiologist to read EKG. It's going to enhance what we can do with reading EKGs and finding problems with patients. Another thing that's important is that this has been consistent in terms of the accuracy with sensitivity greater than 80%, it's about 85%, specificity about 86%, and it's been consistent throughout all racial groups, which is wonderful. Now, in terms of hypertrophic cardiomyopathy, which is where the interventricular septum is very thick, the AI has also shown very good sensitivity and specificity for determining that in a patient. Here's an example of a case where it's a 25-year-old woman with hypertrophic cardiomyopathy. As a cardiologist, one would not be able to look at this EKG and know that that person has a very thick heart. But the AI read this as 72% probability of hypertrophic cardiomyopathy. So we have people having EKGs every day. And in most cases, we say, well, it looks great. But we're missing some people who have weak hearts. And they eventually come back, it may be weeks or months later, which we could have found out months to years earlier, probably, because the body is designed, is very well designed to win that last battle. We have to have about 75% of any organ not doing its function for us to have symptoms. You know, so it's very well designed carbon-based system. But so this young lady had surgery. Now after surgery, EKG looked a little abnormal. But the AI says on this patient that, and after surgery, 2.5% probability of hypertrophic cardiomyopathy. So she had a myectomy where the thick muscle was removed. You know, and most cardiologists would have read the EKG has been a little abnormal. The AI said, oh, everything's fine. You know, so this is wonderful, you know. You can track, you can follow patients this way in terms of how well they're doing and how well are they not doing. So what about atrial fibrillation? Well, it's been shown that with that there's a threshold for the measurement they do that's been done with AI to say the probability that someone has had AFib, although the EKG may not show it at the moment. So right now, there's been FDA clearance for ECG low ejection fraction. That's been cleared. There's pulmonary hypertension validation is being done, cardiac amyloidosis validation, pre-submission for hyperkalemia, AFib and sinus rhythm, hypertrophic cardiomyopathy, aortic stenosis, which we see quite often now. It's an epidemic. So these things are all going to be submitted, are being studied, they're going to be submitted to FDA for approval. What we're going to get here in Fairbanks is the capability to do what Mayo is doing right now, and that is to have AI help us to look at EKGs to make a diagnosis earlier. And as more and more capabilities become available, we will already be in the loop to do this, which is just amazing. Other things that I saw at the conference, radiologists are already using AI when they look at angiograms to determine if someone has had a pulmonary embolism or not. There's a little light on the left-hand side of the console, and the AI will flash or whatever if it thinks it saw a pulmonary embolism. And then so the radiologist can take a closer look if the radiologist didn't see it. AI is also being used to look at one's face to know if someone has diabetes. And just so many different aspects in terms of what's going to be done. This is important for us to know, that in terms of medical knowledge and how fast we're learning things. Back in 1950, the doubling time for medical knowledge was 50 years. By 1980, it was down to 7 years for medical knowledge to double. In 2010, it took only 3.5 years. And there was an article published in 2011 projecting that the doubling time by 2020 would be only 73 days for medical knowledge to double. It's almost impossible to keep up, you know. That's but we're going to have these assistants, right? It's just nice to be able to have a personal assistant who never gets tired of having questions asked, you know? And it's just wonderful. I mean, I'm just so happy to be alive now. I mean, I just wasn't cut out to be just with horses and buggies. I mean, it was nice, but I mean, you know, it's just to be able to do this, to learn, to know. And, you know, so I am a scientist. And I became a scientist when, wanted to become a scientist when I looked up the word science because I wanted to know what it meant when I was 10, 11 years old. And it said to know. Science means to know. And I said, well, I want to know. I want to be a scientist. And so we're going to have so many questions, no matter what you do in life, to have the assistance of a knowledge base of so many that, you know, won't forget. You can always look things up again and test. So Dr. Chang, one thing he was excited about is that, so he's a pediatric cardiologist. And throughout the world, there are children who do not have access to pediatric cardiologists. And they have, may have cardiac problems or whatever. There are networks now where if a child has a problem, then information can be uploaded to centers where there are pediatric cardiologists so they can interact and help give a diagnosis. And AI is helping with that. Another thing that Chang is doing is that when they put symptoms in from a patient, they may get a list of differential diagnosis for a patient, and the cardiologist or the physician may have an idea of what's going on, but the AI may give them more ideas of what might be going on. So the future is bright. It really is. And I think this is going to help all of us to maintain health or to regain health. Okay? Thank you.